Okay, let's start. Good morning, colleagues. Today we will discuss newborn baby, premature baby, and transition states of newborns. During this lecture, we will discuss all etiological factors for prematurity, some milestones of neonatal development, and also we will discuss some reflexes and how to fix some transition states of newborns. Okay, now we'll discuss milestones of prenatal development. First week, during the first week, fertilization and implantation, beginning of embryonic period. And the second week, endoderm and ectoderm appear, bilaminar embryo. Third week, first missed menstrual period, mesoderm appears, trilaminar embryo, and sometimes begin to form. The fourth week, neural false fuse, folding of embryo into human-like shape, arm and leg buds appear, crown rump length about 4-5 millimeters. The fifth week, lens placets, primitive mouth, digital arrays on hands. The sixth week, primitive nose, filtrum primary palate. And during this, at about this period, 6-5 weeks of gestation, we can fix embryo by ultrasound examination. Also, we can fix we can explain for pregnant women that some situation and some pathological factors can cause very strong embryopathy. The 8 weeks, a very test distinguishable, 9-week fetal period begins, and during this period, some pathogenic factors can cause fetopathology. Crown rump length about 5 centimeters, weight about 8 grams. 12 week, external genital distinguishable, 20 week. Usual lower limit of viability, weight about 460 grams, length about 19 centimeters. 25 weeks, third trimester begins, weight about 900 grams, length about 24 centimeters. 28 ISO, one fetus turns head down, weight about 1.3 kilos. And at about age of 38 weeks, we've discussed that it's full-term baby. Okay. Now we'll discuss some periods of some milestones of gestational age and some periods of for a child. First of all, we discuss intrauterine period, and we fix, and it's better to remember that intrauterine period is about 280 days. It's 38-40 weeks. And blastogenesis period from the moment of conception up to 15 days, fertilization of the ovum and implantation of the blastocytes in the uterus. Pathogenic factors can cause abortion or can cause some serious embryopathy. The period embryogenesis from 16th to 75th days up to 12 weeks of gestation, formation of internal organs and organogenesis, embryopathy, growth development anomalies, the age of the fetus from the 3rd to 7th weeks is a critical period of development. And why it's a critical period? Because all tissues and organs start to form, and also all negative factors can cause very serious anomalies. That's why it's better when you work with young women or if you work with pregnant women, it's better to analyze about pregnant status, and if you prescribe some drugs that can cause serious damages for pregnant women, it's better to prescribe just express test for pregnancy, and only after that it's better to just prescribe some medicine. A period of fetogenesis, formation of the placenta from the 76 to 280 days, early fetoepiphysis and late fetoepiphysis. To be honest, embryopathy more serious and cause more dangerous condition than late fetoepiphysis, but sometimes they are similar like earlier fetoepiphysis just in comparison, but it's very rude to say that it's just small animals. All of these conditions very serious. That's why it's better to analyze all situations that happened during the pregnancy with pregnant women, in order what was the reason for this disease that you fix during the examination your patient. Okay, look at this, early fetoepiphysis, 12-22 weeks of gestation, and some anomalies, some dangerous factors can cause hyperplasia or dysplasia. Late fetoepiphysis, 20 to 40 weeks, delay of intrauterine development of the fetus, prematurity, also hypertrophy, antenatal hypertrophy, antenatal hypertrophy, the reason some dangerous factors also can cause not only prematurity or some intrauterine development, delaying of intrauterine development. Also, it can be the reason for the hypertrophy can be some dangerous factors during the 20 to 40 weeks of gestation. Okay. Once again, somatic development, embryonic period. By 6 days post-conception age, as implantation begins, the embryo consists of a spherical mass of cells with a central cavity, the blastocytes. By the second week, implantation is complete and uteroplacental circulation has begun. The embryo has two distinct layers, endoderm and ectoderm, and the amnion has begun to form. The third week, the third primary germ layer, mesoderm, has appeared, along with a primitive neural tube and blood vessels. Paired heart tubes have begun to pump. During the 4th and 8th week of gestation, later folding of the embryological plate, followed by growth at the cranial and caudal ends, and the budding of arms and legs, produces a human-like shape. Precursors of skeletal muscles and vertebrae sometimes appear, along with branchial arches that will form the mandible, maxillipalate, external ear, and other head and neck structures. Lens placets appear, marking the set of future eyes. The brain grows rapidly. By the end of the 8th week of gestation, as the embryonic period closes, the remnants of all major organ systems have developed. The crown rump length is about 3 centimeters. It's better to fix some key point. I will give you 1 minute for fixing this information, because it's very important for your understanding of milestone periods of gestation. Okay, fetal period. From the ninth week on, somatic change consists of rapid body growth as well as differentiation of tissues, organs, and organ system. By the 10th week of gestation, the face is recognizably human. The mid-gut returns to the abdomen from the umbilical cord, rotating counterclockwise to bring the stomach, small intestine, and large intestine into their normal position. That's why some pathogenic factors can cause an anomaly of position of intestine, or transversion of intestine, or some situation then like amphibole or something like this, and it's just the period of only 10 weeks of gestation. That's why it's better to plan the pregnancy, analyze the condition of pregnant women, and also pay attention to all medication, and try to avoid infection disease, because this period of gestation is very important. By the 12th week of gestation, the engine of the external genital becomes clearly distinguishable. Lung development proceeds with the budding of bronchi, successively smaller divisions. By the 20-24 weeks of gestation, primitive alveoli have formed and surfactant production has begun. 20-24 weeks of gestation, look at this, surfactant production has begun. Before that time, the abscession of alveoli renders the lungs useless as organs of gas exchange. During the third trimester, weight triples, length doubles as body stores of protein, fat, iron, and calcium increase. Okay, I will give you 1 minute in order to fix this information, and after that we continue. Okay. This is the example of amphibole. We've discussed that, 10 weeks of gestation, the stomach, small intestine, large intestine, transversion in normal position. This is the situation then we can observe from cell. Okay, neurological development. During the third week, a neural plate appears on the ectodermal surface of triluminal embryo, and finally produces a neural tube that will become the central nervous system, and a neural crest that will become the peripheral nervous system. Third week, neural plate, the peripheral nervous system. Neuroectodermal cell differentiate into neurons, astrocytes, oligodendrocytes, and epithelial cells, whereas nuclear cells are derived from mesoderm. I just fix some key point. You also can write only key point. By the fifth week, the three main subdivisions of forebrain, myloid brain, hindbrain are evident. The dorsal and ventral horns of spinal cord have begun to form, along with peripheral motor and sensory nerves. Melanization begins at mid-station and continues for years. By the end of the embryonic period, the 8th week of gestation, the gross structure of the nervous system has been established. On a cellular level, neurons migrate outward to form the 6 cortical layers. Migration is complete by the 6th month, but differentiation continues. Axons and dendrites from synaptic connections at a rapid pace, making the central nervous system vulnerable to teratogenic and hypoxic influences throughout gestation. Once again, teratogenic factors hypoxic influences is very important for just formation of nervous system. By the time of birth, the structure of brain is complete. But we discussed when it's term pregnancy, not for premature baby. Synapses will be sprung back subsequently and new connections will be made, larger as a result of experience. Many psychiatric and development disorders are thought to result at least in part of disruptions in the functional connectivity of brain networks. Disorders of connectivity may begin during fetal life. MRI studies provide a development timetable for such connections that lend support the possible role of disruptions in the establishment of such connections during fetal life. Okay, behavioral development. No behavioral evidence of neural function is detectable until the third month. Third month, no behavioral evidence. Reflexive responses to tactile stimulation develop in a craniocaudal sequence. By the 13th-14th week of gestation, breathing and swallowing motions appear. 13, 14, breathing and swallowing motions. The grasp reflex appears at 17th week and is well developed by 26 weeks. Eye opening occurs around 26-28 weeks. By mid-gestation, the full range of mental movements can be observed. Okay, 13-14 breathing and swallowing. The grasp reflex appeared at 17 week, well developed 27 week. Eye opening 26-28 week. During the third trimester, fetus respond to external stimuli with the heart rate elevation and body movements. As of infants in the postnatal period, the activity to auditory, brachioacoustic, and visual bright light stimuli vary. Depending on the behavioral state, which can be characterized as quiet sleep, active sleep, or awake. Individual differences in the level of fetal activity are commonly noted by mothers and have been observed ultrasonographically. That's why some perinatal psychologists describe some influence or some exercise or some stimuli that it's normal to just develop the neural system of just fetus. That's why we've discussed some music that we prescribe for pregnant women, or we'll discuss some just walking, or we'll discuss communication with the stomach in situation the mother just sometimes stimuli, or just read book, or just speak with the stomach. I mean that mother have communication with the future child. Just this is the special music list for just pregnancy women, or special music list for just labor. Fetal behavior is affected by maternal medications and diet. all medication and diet can be the reason of have some influence for fetal behavior, increasing after ingestion of caffeine. Behavior may be trained to the mother's diurnal rhythms, sleep during the day, active at night. Abnormal fetal movement patterns are found in neonates which are these subsequent muscular or neurological abnormalities. Fetal movement increases in response to a sudden auditory tone, but decreases after several repetitions. This demonstrates habituation, a basic form of learning in which repeated stimulation results in a response decrement. With the tone change in pitch, the movement increases again, which is evidence that the fetus distinguishes between a familiar, repeated tone and a novel tone. Habituation improves in older fetuses and decreases in neurology impaired or physically stressed fetus. Similar responses to visual and tactile stimuli have been observed. Okay, fetal behavior is affected by maternal medication and diet. For example, we discussed in effects of caffeine. Fetal movement increases in response to a sudden auditory tone, some loud music, some movements, even when they fix cardiotopography, they can ask pregnant women to eat, for example, chocolate or something sweet, or even cough or laugh in order to stimulate the movements of the fetus. Okay, once again, one of the examples of influence is just music. Okay, perinatal period from the 22 weeks of gestation to 7 days of life. And we've discussed that first 7 days of life is early neonatal period. It's very important period, and we will discuss it during this lecture. And some pathogen factors that can cause during the perinatal period can be the reason for perinatal mortality or some other situation. And look at this, perinatal period, it's not only antenatal period, it's also intranatal period and postnatal period. Postnatal period includes 7 days of life. Neonatal period. Neonatal period, it's first 4 weeks of life. We have early and late neonatal period. Early neonatal period from birth to 7 days of the life. Late neonatal period from first week from 7th day to 28 days of life. Once again, neonatal period 28 days. Early neonatal period first 7 days of life. Late neonatal period from 7 to 28 days. And it's very important to discuss some problems like mortality and just the situation when we discuss perinatal mortality. We should remember that they prescribe NICU, neonatal intensive care unit, for newborn baby from 22 weeks of gestation with weight more than 500 grams with one of the signs of live birth. This 5 position of the signs, if we observe even one signs, we prescribe NICU. And it's better to fix that signs of live birth is breath, heartbeat, pulsation of umbilical vessels, spontaneous muscle movements. Newborn baby. Once again, it's better to repeat, full-term baby. Gestational age is about 38, 42 weeks. This is more important information. Less important information that is length more than 46, weight more than 2.5 kilos. Why? Because they discuss full-term premature or baby or post-term only analyze the gestational age. Premature baby, gestational age is less than 38 weeks, length less than 45 centimeters, weight less than 2.5 kilos, signs of morphofunctional immaturity. And the classical example, this is a normal ring, to be honest it's male ring, and this is the small length of premature baby. External signs of prematurity: wrinkled skin, lack of subcutaneous fat, soft ears, ample voluminous hair, underdevelopment of genital organs, low navel location, not overgrown cranial sutures, open fontanelles. Look at this. This is the soft ear, very small amount of subcutaneous fat, wrinkle, skin, just the color of the skin, and also we can observe the just hair from lanuga, and we have 4 degrees of prematurity. First degree, gestational age 37-35 weeks, body weight approximately about 2.5 kilo. The second degree, 34-32 weeks, body weight is about 2 kilo, from 2 kilos to 1.5 kilo. And for the other classification, we've discussed this classification last Saturday. Low body weight, LBW, it's 2.5, 1.5 kilo. It's better to fix this information. I will give you 1 minute in order to fix. Okay, the third degree, gestational age is about 29-31 weeks, body weight 1.5, 1 kilo, and this is except this classification for the weight of a premature baby. 1.5, 1 kilo is very low body weight. VLBW, very low body weight, third degree of prematurity, 31-29 week of gestation. 1 minute to fix. Okay. The fourth degree of prematurity, the most severe degree, gestational age is about 22, from 22 to 28 weeks of gestation, body weight less than 1 kilo, and once again we prescribe an ICU for the newborn baby with age, with weight more than 50 grams, more than 500 grams. Once again, 22 weeks of gestation, 500 grams, one signs of it can be a heart bump or can be just even just pulsation of the umbilical cord, or it's just spontaneous movements, or it can be some breathing movements. They start an ICU, and this is the most severe degree of prematurity, the fourth degree, and for classification of the weight, this newborn baby extremely low body weight, ELBW, less than 1 kilo, 500 from 500 to 1000, extremely low body weight. Okay, postpartum baby, 42 weeks of gestation or more morphological characteristic of post-maturity. 42 weeks of gestation or more, and you can fix or find some morphological characteristics of post-maturity. You can think that postpartum baby, why it's a problem? They are just very healthy, good weight, good length, but just imagine some fontanelles closed and some structures of the skull become more the situation then some fontanelles and structures of the skull close the movements and the all condition that can some during the internatal period, some internatal traumas occur more often, will occur more often. Internatal traumas occurs often for postpartum baby because their weight and length more in comparison with just full-term baby. And signs of post-maturity: dryness of the skin, peeling, maceration of the skin, meconial staining in the umbilical cord and placenta membranes. Why? Because more often hypoxia occurs in situation than its prolongation of gestation age more than 42 weeks. That's why it's better to prescribe cesarean section in situation than prolongation of gestation of pregnancy occurs, and try to avoid the situation that it's a postpartum baby with very with weight more than 5 kilos or more than 800 grams. Okay, premature baby. Risk factors for prematurity: maternal toxemia, structural abnormality of the uterus, chronic maternal illness, infections, for example, chorioamnionitis. Woman is over age 35 or under 19 years old, multiple fetuses, Mara's lifestyle, like smoking, alcohol, drugs, poor diet, not gaining enough weight, exposure to physical stress, or poor parental care, or unknown factors. Look at this, multiple fetuses is one of the situation when it's prematurity or cursory, because to be honest, the multiple fetuses with gestational age more than 37 weeks of gestation, it's a very rare situation. That's why multiple fetus is one of the risk factors for prematurity, and your prenatal care for pregnant women with multiple fetuses should be more intensive. Okay, we've mentioned a neonatal intensive care unit, but we haven't discussed it yet. That's why it's better to discuss what does it mean, NICU, neonatal intensive care unit. Premature infants have many special needs that make their care different from that of full-term infants. The NICU is designed to provide an atmosphere that limits stress to the infant and meets basic needs of warmth, nutrition and protection to assure proper growth and development. Just imagine 24 weeks of gestation, some risk factors occur, and we just have 24 with we have a premature baby with extremely low body weight and the 4th degree of prematurity, and your intensive care unit should be like a situation of we should like in utero. The atmosphere should be like in utero in order to grow. Warmth and humidity. Premature babies lack of their body fat necessary to maintain their body temperature, even then swaddled with blankets. Okay, basic needs. Incubators are made of transparent plastic, and they completely surround an infant to keep him or her warm, decreasing the chance of infection and limit water loss. Radiant warmers are electrically warmed open beds. These are used when the medical staff needs frequent access to the body care. Warmed open beds and incubators. And also we have transport incubation in order to just transfer baby from labor room to the neonatal intensive care unit department. Also look at this, we minimized all stress factors, and even the atmosphere should be darkness, and we avoid very loud sound in order to minimize the stress. And after birth, we give for premature baby about 1 hour to just stay in unstressed atmosphere in order to just transfer from intrauterine to the normal atmosphere condition. Nutrition and growth. Most premature infants have to be fed slowly because of the risk of developing necrotizing enterocolitis, very dangerous surgery condition. Sometimes we need we need an operation in order to fix these problems. That's why first of all we try to feed parenteral, and after that we transfer to the just formula feeding or breastfeeding. The low body weight babies need high caloric intake, glucose and fluids that cannot be given via the gut in the first days, weeks of life. We use total parental nutrition formulas. Breast milk is an excellent source of nutrition, as it has an advantage over formula because it contains proteins that promote growth and immunoglobulins that helps fight infection. Special fortifiers may be added to breast milk because premature infants have higher vitamin and mineral needs than full-term infants, and also premature baby needs more protein in order to just during the pregnancy they need about 3.5 grams of proteins per weight, and to be honest, the amount of proteins in breast milk is about 1.8 from 1.8 to 2 grams per liter. That's why they need this extra amount of proteins, and we use special fortifiers in order to add more extra protein to a breast milk. Nearly all premature babies receive additional calcium and phosphorus either by adding fortified to breast milk or directly through special formulas for preemies. Why? Because we are just afraid neonatal calcium, that's why, and some seizures, that's why we prescribe extra donation of these elements. Complications of prematurity. We have all organs and systems, they have some complication for prematurity, and they discuss the matcha. Neurological, intraventricular hemorrhage, periventricular epilepsy, development delay and or CP, deafness, blindness due to retinopathy of prematurity, respiratory, RDS or PPD, apnoea, cardiovascular, low body pressure, PDA, gastrointestinal, spontaneous perforation, necrotizing enterocolitis, Jordan's, hematological, anemia of prematurity, and infections. I will give you 1 minute to fix complications of prematurity: neurological, respiratory, cardiovascular, gastrointestinal, hematological, and infections. Okay. Intraventricular hemorrhage, IVH, spontaneous bleeding into the ventricles of the brain due to a weakness of the blood vessels next to ventricles of the immature brain in the area named seminal matrix. It involves as the infant approaches full-term gestation and the tissue's vascular integrity improves. Therefore, the risk of bleeding is inversely related to gestational age and birth weight, with the smallest and most immature infants being at the highest risk. Approximately 30% of premature infants less than 1.5 grams of and in classification it's sometimes third and fourth degree of prematurity have intraventricular hemorrhage. Spontaneous bleeding into the ventricles of the brain. Look at this, thickness of the blood vessels next to the ventricles of the immature brain, area and chemical matrix. Intraventricular hemorrhage. Risk factors for IVH, prematurity, it's the high risk, also respiratory distress syndrome, pneumothorax, hypoxic ischemic and hypotensive injury, increased or decreased cerebral blood flow, hypervolemia, hypertension, and thrombocytopenia. 50% of the cases are diagnosed within the first day of life and up to 75 within the first 3 days. The majority of infants have no clinical symptoms. That's why we prescribe ultrasound examination for all premature baby in order to fix this condition. Some may have acute deterioration on the second or third day of life, including apnea, pallor, decreased hematocrit, cyanosis, abnormal eye signs, high-pitched cry, convulsions, decreased muscle tone, hypertension, metabolic acidosis, and shock. It's better to fix risk factors. Remember that majority of infants have no clinical symptoms. Some may have acute deterioration on the second, third day of life, and okay, ultrasound. I've mentioned that ultrasound is very important for diagnostic intraventricular hemorrhage. The severity of hemorrhage is defined by the location and degree of ventricle dilatation. Grade 1 hemorrhage, bleeding is isolated to the subendominal area. Grade 2 hemorrhage, bleeding within the ventricle but without evidence of ventricle dilatation. Grade 3 hemorrhage, intraventricular hemorrhage with ventricle dilatation. Grade 4, intraventricular and parenchymal hemorrhage. It's better to fix the classification. I will give you 1 minute. Okay, intraventricular hemorrhage, approximately 10–15% of very low birth weight infants have post-hemorrhagic hydrocephalus, and 3–5% require ventricular peritoneal shunt insertion. That's why you can meet this patient with this shunt. If the initial US is abnormal, additional interval studies are indicated to monitor for the development of hydrocephalus. Premature infants less than 32 weeks of gestation are evaluated with routine cranial ultrasounds for the anterior fontanel to screen for IVH in the first week of life. All at-risk infants should undergo follow-up ultrasounds at 36-40 weeks of postmenstrual age to evaluate adequately for periventricular echinacea, because cystic changes related to perinatal injury may not be visible for at least 2 to 4 weeks. As for Russian Federation, they prescribe ultrasounds during first 3-5 days of life, and the next ultrasounds examination for all infants. It's we have no variation post-term, full-term, or premature baby. For all baby is just the rule first 3 days of life, and one more is from we prescribe for the 1 month of the life. 2 ultrasounds examination in order to fix some injury or some abnormalities, and prescribe treatment as fast as we can. Intraventricular hemorrhage, the degree of IVH and the presence of periventricular echinacea are strongly linked to neurodevelopment impairment. Infants with birth weight less than 1 kilo, it's extremely low birth weight, the incidence of severe neurological impairment, defined as mental development index less than 70, cerebral palsy, blindness, or deafness, are about 50%, 55%, and 70% for infants with grade 2, grade 3, and grade 4 intraventricular hemorrhage, respectively. That's why then you analyze the future of baby with intraventricular hemorrhage. It's better to just analyze the rate of IVH, and you can give some maybe perspective or analyze the maybe amount of rehabilitation program, periventricular echinacea, cystic periventricular echinacea, and progressive hydrocephalus requiring shunt insertion are each independently associated with a poor prognosis. That's why for prognosis it's better to pay attention to the amount of PVL, the stage of IVH, and the just localization of the all injuries. One more dangerous condition is retinopathy of prematurity, ROP. ROP is abnormal growth of the blood vessel in the infant's eye, leading to scarring and vision loss. The risk factors are not fully known, but prematurity and the associated retinal immaturity at birth is present the major factors. Oxygenation, respiratory distress, apnea, bradycardia, heart disease, infection, hypercarbia, acidosis, anemia, and the need for transfusion are contributory factors. It's better to fix what does it mean and all contributory factors. Generally, the lower the gestational age, the lower the birth weight, and the sicker the infant, the greater the risk is for ROP. It is about 7% in 1.25 grams kilos. The basic pathogenesis of ROP is still unknown, but high inspired oxygen concentration are involved. ROP is abnormal growth of the blood vessels in an infant size, leading to scarring and vision loss. There are a lot of contributory factors, and to be honest, we still don't know the pathogenesis, all pathogenesis. In more than 90% of at-risk infants, the course is one of spontaneous fluorescent regressions with little or no residual effects. Less than 10% of infants progress to severe disease and impairment of vision, including cataracts, glaucoma, signs of inflammation, and progressive myopia. Systematic serial ophthalmological examination of infants at risk bear weight of less than 1.5 kilos or gestational age less than 32 weeks are recommended at 31-36 postnatal week. The subsequent follow-up each 2 weeks or less. Laser photocoagulation or anti-VEGF antibody intraocular injections are the treatment modalities for progressive disease. To be honest, as for Russian Federation, more than they prescribe laser photocoagulation, very small percentages of patients have these intraocular injections. Only in just in a small amount of hospital use this treatment. The most prescribing treatment is laser photocoagulation. Okay, apnea of prematurity. Infection, thermal instability, prematurity, metabolic disorders, drugs, inhibitory reflexes, decreased oxygen delivery, they all can be the reason for apnea. Apnea is a common problem in preterm infants that may be due to prematurity and associated illness and is a feature of many primary disease. In term infants, apnea is always worrisome and demands immediate diagnostic evaluation. In the NICU, all preterm babies are monitored for apnea spells. Idiopathic apnea for prematurity occurs in the absence of infantile identifiable predisposing disease. Look at these some factors. Thermal instability, infection, decreased oxygen delivery, inhibitory reflexes, drugs, metabolic disorders, and prematurity can be the reason for apnea. Apnea is a disorder of respiratory control and may be obstructive, central, or mixed. Obstructive apnea, pharyngeal instability, neck flexion is characterized by absence of airflow by persistent chest wall motion. Central apnea is caused by a decreased central nervous system stimuli to respiratory muscles. Airflow and chest wall motion are absent. Gestational age is the most important determinant of respiratory control, with the frequency of apnea being inversely related to gestational age. The most common pattern of adiabatic apnea in preterm neonates is mixed apnea. Mixed apnea, the most common pattern of adiabatic apnea, with obstructive apnea presenting usually or following central apnea. Once again, apnea of prematurity, obstructive, central apnea, and mixed apnea. The onset of idiopathic apnea can be during the first 1 to 2 weeks, and spells become less frequent with age. Serious apnea is defined as cessation of breathing for longer than 20 seconds, or for any duration accompanied by cyanosis and bradycardia. Gentle tactile stimulation is often adequate therapy for mild and intermittent episodes. That's why you should explain for women with premature baby how to stimulate or what to do with premature baby. Gentle tactile stimulation is often adequate therapy. Once again, gentle tactile stimulation, just They stimulate skin, just small shaking movements. Methyl contains terphyllin or caffeine, increase central respiratory drive by lowering the threshold of response to hypopnea as well as indicating contractility of the diaphragm. Nasal continuous positive airway pressure, nasal CPAP, continuous positive airway pressure. Nasal continuous positive airway pressure, nasal CPAP, or high flow nasal cannula may reduce apneic spells. CPAP, nasal cannula. We've discussed PDA, its patent ductus arteriosus, a short blood vessel that connects aorta with pulmonary artery and allows blood to bypass the fetal lungs, as oxygen comes from the placenta. In full-term babies, the ductus closes shortly after birth. Their physiological close is about 10-15 hours after the birth. At the age of 1 month, we have anatomically closed. Excess blood flows into the lungs and can cause breathing difficulties, apnea, desaturation, and heart failure. Patent ductus arteriosus is associated with BPAD and NEC. PDA is treated with indomethacin or ibuprofen, and if medical therapy fails, surgical ligation is required. Just imagine we can fix congenital heart disease with prescribing the medication. We have a parental form of indomethacin PDM, or we prescribe parental form of ibuprofen, or we prescribe indomethacin or ibuprofen parental, or even enteral form. In situation then we can't fix with prescribing of medication, we discuss surgical operation. Normal blood pressure, mean BP, gestational age index. Low body pressure is a common complication that may occur shortly after birth, usually due to blood loss, interventricular hemorrhage, or later due to infection, sepsis for example, fluid loss, patent ductal arteriosus with heart failure, or necrotizing enterocolitis. In very low birth weight, extremely premature or very sick infants, we must monitor blood pressure by umbilical artery, catheter placement, or non-invasively. Non-invasively with just some monitors. Hypertension is treated by fluid bolus and sometimes with RBC or plasma transfusion. Anemia of prematurity. We have early and late anemia of prematurity. Near-term cord blood hemoglobin is about 14-20 grams per deciliter, while hemoglobin levels in very low birth weight infants are 1-2 grams below those. A physiological decrease in hemoglobin content is noticed at 8-12 week term infants. Physiological decrease of hemoglobin for full-term baby is normal at the age of 2-3 months of life, but as for premature infants is about 6 weeks repeated. And what is the reason for anemia of prematurity? Repeated phlebotomy for blood tests, shortened RBC survival, rapid growth, and acute blood losses, for example for IVH, contribute to anemia of prematurity. That's why when you prescribe blood test for premature baby, you should analyze do you need this information? Does this information change anything, or do you need to monitor some situation, or you just can postpone this test? Why? Because, for example, for biochemical test we need more than from 1 to 5 milliliters, but the just amount of blood in just infant is about 80 100 grams per weight per 1 kilo weight. For example, your premature baby is extremely low per weight, and the weight of this premature baby is only 500 grams, and even 1 milliliters is very important, because the amount of blood is only 40 milliliters. The just amount of blood in circulation in just blood circulation circle, 40 milliliters, even 1 milliliters is very important. That's why when you prescribe blood test, analyze the do you need it or does this test is very important. Neonates erythropoietin response is attenuated for the degree of anemia, and as a result hemoglobin and reticulocytes level are low. Clinically manifests as a pallor, poor weight gain, decreased activity, tachypnea, tachycardia, and feeding problems. Treatment of neonatal anemia by blood transfusion depends on the severity of symptoms, the hemoglobin level, and the presence of comorbid disease, RDS, BPD, or cyanotic congenital heart disease that interfere with oxygen delivery. The need for treatment should be balanced against the risk of transfusion, including hemolytic transfusion reactions, exposure to blood products, volume overload, possible increased risk of PO and NAC, transfusion acute infection. That's why you should analyze the severity of anemia and analyze all risk factors. Preterm infants who have repeated episodes of apnea and bradycardia despite terfalin therapy and hemoglobin level less than 8 grams per deciliter may benefit from RBC transfusion. Infants with RDS or severe BPD may need hemoglobin levels of 12-14 grams per deciliter to improve oxygen delivery. No transfusion is needed to replace blood removed from testing or mild asymptomatic anemia. Recombinant human erythropoietin may be considered in the treatment of chronic or anticipated anemia in an attempt to decrease or eliminate transfusions. Early initiation of erythropoietin therapy may produce a small reduction in the total transfusion volume per infant. As there are concerns about an increased risk of severe ROP in the EPO-treated infants, it is usually not given in the first week of life. Therapy with erythropoietin must be supplemented with oral iron. Once again, erythropoietin with oral iron. Okay. We finished our part of the lecture with premature baby. Now we will discuss mostly full-term baby, transition states of newborns. One of the most not popular, it's not correct term, the percentages of infant that can just have this condition is very high, and it's one of the most typical tension states of newborn. It's the physiological judgments. Physiological judgments from the starts at 2 or 3 days of the life and at the end of the second life of victory of the life. In premature baby, it can postpart, and it can be at the end of the first month of the life. And you should analyze the level of Jordans. The normal physiological Jordans is about 200 micromole per liter of bilirubin, and in situation when you can't prescribe biochemical test, you can analyze the localization of yellow color of the skin, and we have Kramer scales. If we have the yellow color of this area is about maybe 100 micromole per liter of bilirubin. The second area is about 150, the third area is about 200, and the fourth area is about 255 and more, and the fifth area is more than 255. Then you observe area free and more. It's better to prescribe a chemical test in order not to not to miss the condition when it's neonatal Jordans. Meteorrhagias. In a newborn girl, the release of blood from the vagina is a normal condition, and the reason for this condition is the transversion of mom's hormones per blood circulation during the pregnancy, and also some hormones postpartum from with mom's breast milk. It's normal, and the amount of blood is less than 1.5 milliliters. We don't need to treat this condition. We just fix and just examine, not to fix more severe condition. Physiological mastopathy, both for male and female infants, appears on the third or fourth days of the life, disappears at the end of the second week of the life. No treatment, just exam, and just not to just miss the more severe condition like mastitis. It's not physiological, of course. This is the infection condition. That's why it's better to just pay attention to all tensions neonate condition. Milia, white and yellow nodules. Look at this, small. 1-2 millimeters in size of the links of nose, chin, forehead, clogged. It's clogged ducts of the sepicus glands. Toxic erythema, 2-5 days of erythematosus spots, the gray-yellow papules or blisters in the center. It's, to be honest, it's not the typical allergy reaction. It's just migration of eosinophils in the skin. It's a reaction of just contamination of mum's and others microbiota to the skin. It's a normal reaction, and we don't prescribe any medication to this condition. Of course, we should differentiate with some other pathological condition of the skin, but neonatal toxic erythema, just a normal physiological condition and no treatment. Transient loss of body weight. Physiological weight loss is expected that newborns will lose some weight in the first 5-7 days of life. Or 5% weight loss is considered normal for a formula-fed newborn. 7-10 loss is considered normal for breastfed babies. Most babies should regain this lost weight by days 10-13 of life. What is the reason? Regurgitation of amniotic fluid, departure of meconium, drying of umbilical cord, removal of damp crease. We have a special tools that can help you to analyze is it physiological weight loss or pathological weight loss. You can use this just newborn weight tool, NEWT, and you just fix the date of birth, time of birth, and weight, and the cesarean section or just vaginal delivery. And this tool will give you just senseless corridors for your babies, and you can analyze is it normal weight loss or just it's pathological weight loss. That's why it's very useful instruments, and you can use these instruments in your work. Okay, and the last part of our lecture we discussed reflexes of newborns. Classification of the reflexes can be primitive reflexes and genetic subprograms. Reflexes response to light touch, grasp reflex, placing, rooting reflex, and the reflex response to pressure and pain. Gallant's withdrawal, cross extension, Babinski, magnet, Babkin, stepping, support reflex for legs and support reflex for arms. It's better to fix classification. A group, primitive reflexes and genetic subprograms, reflex responses to light touch, reflex responses to pressure and pain. 1 minute to fix. Reflex response to kinesthetic stimuli. Tendon reflexes, eye writing reflex, doll's eye, molar reflex, asymmetric tonic neck reflex, ATNR, symmetrical tonic neck reflexes, CTNR, head body and body head writing reflexes. The fourth group, reflex response to visual and auditory stimuli. Blink reflex, visual right-wing reflex, auditory orienting reflexes. The fifth group, reflex response to labyrinthine stimuli. Labyrinthine head writing, tonic labyrinthine reflexes. Reflex response to kinesthetic stimuli. Reflex responses to visual and auditory stimuli. Reflex response to labyrinthine stimuli. Colleagues, if you if you can't fix all these positions, you can repeat lecture because we have recording of the lecture, and you can find all information. Just pause the lecture and fix all information that you need. But I will give you just 1 or 2 minutes in order to fix. Postural reactions, ventral suspension behaviors, Landau reflex or parachute reaction, equilibrium reactions, visual equilibrium reactions, vestibular reactions, postural stabilization reactions. This is the classification of Landau. It's a postural reaction. These reflexes occur at the age of 4 months. Upper Landau reflexes, the second part of Landau reflexes occur at the age of 6 months. Okay, unconditional reflexes. Piper's reflex, reflex of freedom, Gilula, and reflex of opening the eyes. Reflex of support and automatic gait. On a supported bent legs, in the straightened and inclination of forward to baby does 1, 2 steps. Look at this, you just support, not just stable, just support, and you just try to transport baby, and baby just find one to proboscis reflex over, just light touch to the lips of child with stage, And this reflex disappears at the age of 2-3 months. Tenor and mouth reflex, you just press the hand tenor and child opens the mouth. Grasping reflex, capture of the finger and child's head, and also you can Robinson's reflexes when you just try to lift this baby. Bar screwing reflexes, you just put the hand to the feet of the child, child lying on the stomach, and he pushes and crawls like a commando crawl. But it's a reflex commando crawl for at this age. It's not the normal commando crawl we've discussed during the development of neurological system. It's just a reflex of crawling reflex, then you just putting the hand to the feet. Moral reflexes. The child is sharply rounded by the 15 to 20 centimeters. You can just make a loud noise like this on the table, and baby spreads his hand to the sides and then returns. Babinski reflex, just normal plantar response, so just Babinski signs up to the 1-2 years. And primitive reflexes, asymmetric tonic neck reflexes, then baby just turn the head, and they also have symmetric tonic neck reflexes. The condition then it's just symmetric. Okay, for today that's all. We've discussed some prematurity problem, NICU, and tension states for newborn baby. Thank you for your attention. If you need to repeat or to fix some information, you can find the recording of lecture at our YouTube channel. Don't panic if you can't fix some information. Just pause the lecture and fix. Thank you for your attention. See you next lecture.